Hello and welcome everyone. So today let's learn about preterm labor, labor that begins before term. So let's quickly start. So first let's start with definition. So what is preterm labor? A labor that starts before 37 completed weeks, okay? Completed weeks from the last menstruational period. That means it is the labor that starts before 37 weeks of gestation from the last menstruational period. And the lower limit for the developed country is 20 weeks and for the developing country it is 28 weeks. Okay. Coming to the incidence and prevalence. So the prevalence ranges from 5 to 10% worldwide. Okay, so that is why it is a significant number which causes perinatal morbidity and mortality. Hence that is why it says that early recognition or early identification of the preterm is the cause of the preterm is important. Okay, so now let's see what are the risk factor and the etiology for preterm labor. First of all, understand that approximately 50% of the cases the cause remain unknown. Okay, so um, there might be everything might be seems to be normal, but still the mother comes to the facility for a labor pain. Okay, and the cause can be unknown. Okay, so the other causes can be of previous history. Any if she had a preterm delivery, her previous delivery was preterm, so then the chances of her having a preterm this time also is high. Assisted reproductive techniques, that is IVF, recurrent UTI, any infection, urinary tract infection, smoking, low socioeconomic and maternal stress can be the cause of um, preterm labor. So the other one is the current pregnancy. If the mother is suffering from preeclampsia, antepartum hemorrhage, premature rupture of membrane, polyhydramnios, cervical incompetence, uterine malformation, and acute infection can also cause preterm labor. So in fetoplacental, if there is a multiple pregnancy, congenital malformation, intrauterine death, placenta infraction, thrombosis, placenta previa, or abruption can also cause preterm labor. Okay, so now how do you diagnose? Uh, so first there are certain clinical signs that as a nurse you need to assist. First is there if there is any if the uterine contraction is regular, that means more than or equal to 1 per 10 second it should be the contraction. Number two, the cervical dilatation. When you do your PV, the cervical dilatation should be more than 2 centimeter. The os should be open, and then 80% effacement. Okay, so there should be a pelvic pressure or backache, and then a vaginal discharge or bleeding should be seen. Okay, and then there are certain things that you need to remember. Preterm labor is very unlikely when cervical length is more than 30 millimeter regardless of uterine contraction. Okay, so now let's learn about the pathophysiology of preterm labor. I've mentioned two pathophysiology. One is due to unknown reason there is going to be a premature activation of parturition, and other one is due to infection. So let's learn about the premature labor. So what it involves, the premature activation of physiological pathway that initiate labor. So what happens is there will be an increase in the placental and fetocorticotropin releasing hormone. So this hormone, CRH hormone, it elevates the fetal adrenal cortisol. So now what this cortisol does, it leads to the upregulation of prostaglandin synthesis and myometrial oxytocin receptor. So both of them, what it does is, like, the prostaglandin actually helps in repairing of the cervix, effacement of the cervix. And then myometrium, what happens, it becomes sensitive to oxytocin. Okay, so additionally also what happens is that the functional progesterone withdrawal overcomes its inhibitory effect. So here what happens, the progesterone and estrogen ratio alters. Okay, there is an alteration here. So what happens, there is a decrease in the progesterone and increase in the estrogen. So which what it does is, which eventually increase the gap junction protein and contraction associated protein. So now this protein results into coordinated uterine contraction and cervical effacement. Okay, so now if the preterm labor is due to infection, what happens? There is an invasion of a microbial or microorganism. So what happens, if there is an infection, it is actually a primary trigger. So what happens here, the pathogen associated molecular pattern activates the toll-like receptor. Okay, so where does it activates? On the immune and the decidual cell. Okay, so now this, what happens, this initiates the nucleofactor kappa B cell pathway, and now this robust inflammatory cascades releases pro-inflammatory cytokinase. Okay, so which stimulates the cyclooxygenase 2, so which produce in the decidua and the myometrium. Okay, so what happens, eventually there is a surge in the prostaglandin. Okay, so and this prostaglandin directly induce the myometrial contraction, and then cervical repairing happens. Okay, so now let's learn about the management. So we learned the definition, what is preterm labor, and how to identify or diagnose preterm labor. So now let's see how to manage it. Okay, so first is the use of corticosteroids. Okay, which is betnesol. We have two drugs that will be that is in use. But one is betnesol, the other one is betamethasone and dexamethasone. Okay, so betamethasone we give 12 mg IM 24 hours apart. Okay, whereas dexamethasone we give 6 mg IM 12 hours apart, and this is given for lung maturity of the baby. Okay, we will also be giving a tocolytic drugs, that is like either nifedipine or atosibane. This is given, and this it is a tocolytic drugs, so that it can delay the delivery for at least 48 hours. Okay, and we also will be giving magnesium sulfate for those preterm which is if the gestational age is less than 32 weeks. Okay, if the gestational age is less than 32 weeks, then we'll be giving magnesium sulfate. So magnesium sulfate, don't get confused. Here we are it is not that the mother is diagnosed with preeclampsia. Here we are giving it for neuroprotection of the baby. Okay, and how do we give magnesium sulfate? It is exactly how we give for a preeclampsia mother. It is like the first loading dose, all the 14 gram of magnesium sulfate, which is 5 gram each buttocks IM, and then we give 4 a gram through IV. Okay, and after that you will be giving maintenance dose, that is 4 hour apart. Every 4 hourly you will be giving 5 gram alternative buttocks for 24 hours. And then it is suggested that if the mother is in a peripheral facilities, like maybe if she is in a sub center or a PHC, it is better to refer the mother to the tertiary center, so that you have an NICU facility there. Okay, Okay, so now let's see what all, as a nurse, what all you need to do during labor time, the management of management during labor. Okay, so in the first stage, make sure that you give the mother a proper bed rest. Ask her to lie down in the left lateral position. Okay, and then you need to continuously monitor the fetal heart rate, which through electrofetal monitoring. You can also give epidural analgesic, oxygen therapy, and also make sure that you prevent early membrane rupture. Okay. Number two, during the second stage, during the delivery of the baby, make sure that the delivery is gentle and slow so that you prevent head trauma. Okay, give episiotomy if required. Number two, and also number three, avoid routine forceps like using of a forceps or vacuum. Okay, after that you need to practice delay cord clamping. Okay. Number three, the delivery method should be vaginal. The preferred one is the vaginal delivery. Cesarean section should be considered only if it is indicated. But in a breech presentation with less than 34 weeks of gestation, then it will, in that case, cesarean section is required. So now lastly, let's learn about the nursing care. Okay, so the first is that you need to assess the mother and monitor the mother. Okay, first is what all you need to do, check for the vital signs every 15 minutes for 1 hour, and after that half an hour. Okay, and then check for a uterine contraction, fetal heart rate, cervical changes, fluid balance, and sign for infection. That can be fever and foul smelling discharge. Okay, so these are the sign of the infection. Number two, make sure that you administer the medication. Those are like tocolytic agents, which we did study in the previous slide, which is like nifedipine, using of nifedipine. Okay, and you need to also monitor for any side effects. Okay, ensure that the glucocorticoids, which is like dexamethasone or betnazole, is whichever medication you have given is completed. Okay, and then if at all the mother is in the magnesium sulfate, that also you need to monitor. Okay, if the pregnancy is less than 32 weeks of gestation. And so, and number three, it is very important to give a patient education, which is you need to explain the condition and the treatment that is going on, and teach a warning sign. If any kind of warning sign you see, you need to inform it. Yeah, and then provide emotional support and involve family in the care planning. Okay. Number four, preparation for delivery. So make sure that you coordinate with the neonatal team. You need to call them up and say that you have a preterm mother with you, which is going to be delivered now. So after that, after all the care that you will give in the delivery room, then after that it will be shifted to the neonatal NICU, right? So you need to coordinate with the neonatal team, number one. So make sure you prepare all the emergency equipments. Those are resuscitation bag and mask. Everything should be kept ready, and ensure there is, so if you have coordinated with the NICU team, so there also the staff should be ready. Okay, and make sure that all the intervention that you have done is documented thoroughly. Okay, so if a baby is kept in an NICU, the survival rate for the baby who is of 1 kilo or 1.5 kg, the survival rate exceeds 90%. Okay, so that is why in the earlier slide we talked about that the baby, if at all the baby is in the peripheral facility that like PHC or subcenter, she should be referred to the tertiary care facility. Okay, so the infant born at 26 weeks or 26 weeks have a 80% survival chances with surfactant therapy. Okay, thank you so much. If you like it, please do share with your friends. Do not forget to like and subscribe.